Hi everyone, and thanks for having me here. So my topic is patient-delivered partner therapy for chlamydia, focusing on the situation in Victoria. So the background to this research, I'll present my research findings first and then reflect on the faculty learning objectives. So chlamydia trachomatis is the most common STI in Australia. Although it's usually asymptomatic, it can have chronic consequences including pelvic inflammatory disease, chronic pelvic pain and infertility. So these are the notification rates in Australia since notification data started. As you know, it's a reportable condition. And the notifications have increased 300% in the last 10 years. Victoria basically tracks along the national average, and the Northern Territory has 3 times the national average. And the rates of notification are higher in Indigenous populations. Most notifications occur in the age group 15 to 30 years old, with more females being diagnosed with chlamydia than males, and that more reflects the fact that they're more likely to present to health services and actually get tested. So what is PDPT? It's a form of expedited partner therapy where treatment is prescribed for the index patient and his or her sexual partner. So if you were to diagnose someone with chlamydia, as opposed to waiting for them to go tell their partner, wait for that partner to come in and to then get tested and treated, you basically give them antibiotics for both them and their partner at the same time. It is not intended to replace traditional management. It's supported by numerous bodies and is actually legal in 33 of the 50 US states. At least that was the situation last year when I did this research. In Australia, it's supported by the Australasian Chapter of Sexual Health Medicine, which is part of the RACP, and they actually published some guidelines for its use back in 2009, so this is not really a new idea. They've written to the State Ministers of Health in both Australia and New Zealand requesting that the governments reconsider their legislation to allow the practice of PDPT to provide a health benefit to their relevant citizens. And the Northern Territory was actually the first to respond by legalising the practice in 2012. So the objectives of my research were to review the rationale and evidence behind PDPT, to summarise some of the issues surrounding it, and to evaluate its value as a management strategy in Victoria. The way I did this, I was placed as a student with the Department of Health Victoria with their sexual health and viral hepatitis team, and I undertook some independent research, reviewing internal reports and communication, looking at surveillance data and doing a literature search. And so what did I find? The recommendations for managing chlamydia: regular screening is actually recommended annually in the GP guidelines. Chlamydia is easily and accurately diagnosed on a first-pass urine sample, which is very non-invasive. It's effectively treated with a single oral dose of azithromycin, which confers a 97% cure rate. The alternative treatment therapy is doxycycline for a week. It's then recommended that the patient abstains from sex for 7 days and until all their partners are treated, and that they get retested down the line. So what are the outcomes of chlamydia treatment? Actually, there are very high rates of persistent or recurrent infection. That is, someone testing positive if/when they get around to retesting. So about 15%, or 1 in 7 within 6 months. And quite a low proportion of partners are actually being reached by their partners. And there are lots of factors that would affect that, including stigma, patient and partner characteristics, cultural factors, as well as relationship factors, and there is no legal obligation to tell somebody that you had chlamydia. So the rationale behind PDPT is that it will increase partner notification and treatment, and hopefully make that conversation of, hey, I've got an STI, a little bit easier if you've got the solution in your hands as well. It also aims to prevent reinfection of the index patient and thereby reduce the sequelae of disease. So pelvic inflammatory disease, for example, is 6 times more likely with recurrent infections. By reducing the number of, reducing reinfection and increasing treatment, hopefully transmission will be reduced, and the overall prevalence and incidence of infection will also be reduced. So what is the evidence? There was a systematic review published in the BMJ back in 2007 looking at PDPT over 6,000 patients in the US, the UK and Uganda, and it showed that there were reduced rates of reinfection of the index patient. So absolute risk reduction of 3.7%. That's based on whether 10% of people had repeat or recurrent infection. So we know that that rate's more around 15%, so that'd bring it down to somewhere under 10% testing positive at retesting. And it showed that more partners were notified and treated with PDPT compared with standard patient referral. Azithromycin is safe in both pregnancy and breastfeeding, has very mild side effects, GI side effects like diarrhea, and it doesn't interfere with the oral contraceptive, nor moderate amounts of alcohol, and it can be taken before or after food. That doesn't really matter. It's also been shown to be a cost-saving and cost-effective solution. For less money, you can treat more partners and reduce the rates of pelvic inflammatory disease. So obviously there are lots of risks and concerns with any new sort of idea. I guess a big one is treating an unseen partner and the fact that STIs come in groups. So by sort of bypassing the whole normal workup, there are some infections that you might be missing. And these rates of infection are much higher in the population than men who have sex with men population, to the point that a lot of guidelines, a lot of bodies will recommend that PDPT only be used in heterosexual relationships. There's also a lost opportunity for education, because you never get to see this patient, and there's no further contact tracing. But I guess on the other side, you would argue that these are the patients or partners who would never have presented in the first place, so therefore, you know, treating them that little bit is something, and it's better than nothing. The legal and professional ramifications are another concern. So if there were to be an adverse reaction, you know, would the clinician be responsible for that? There was another interesting study that showed that whether PDPT was legal, illegal, or grey, about 50% of practitioners were using it anyway. Okay, so the conclusions of my research were that the benefits of PDPT outweigh the risks, and it should be available as an additional strategy for heterosexual partners who are unlikely or unable to attend promptly for clinical services, and would recommend providing a framework to allow the use of PDPT in Victoria and Australia, I guess, and New Zealand. And that would include providing a legal position, guidelines for use, as well as supporting clinicians to actually use PDPT. And that can include things like information handouts for if you are giving these medications, and of course a method of assessing outcomes, and especially recording any adverse events that might occur. So in regards to the learning objectives, chlamydia is obviously an increasing problem in Victoria and Australia, but PDPT is only really one small part of what should be a multifaceted approach. Even just facilitating partner notification with education has been shown to reduce persistent or recurrent infection. Something really scary that I found out was that they did a survey of high school students in 1997, 2002 and 2008. It showed that a large percentage of them are sexually active, and yet only 50% always using barrier protection, and that figure has not significantly changed in the last 10 years. Screening is also something that there's a lot of room for improvement on. So 85% of females and 65% of males in the target age group will attend a GP per year. And even though it is in the GP guidelines, only 8% of them are actually being tested for chlamydia. And even if someone's tested positive for chlamydia and been treated, very few of them are actually being retested. So another learning objective that I reflected on was the use of evidence as a basis for public health practice. With PDPT, there's an inherent sort of loss to follow up that sort of underlies the whole rationale behind it. And even in objective data, looking at notification rates, I sort of touched on before that it's not really indicative of true notification rates or the population. So just being aware of the weaknesses in existing evidence. There's also not really any Australian data or trials of PDPT, as you would expect, given it's not legal. And despite, all this evidence actually existing, there's, as you can see, there's been multiple years and a lot of this evidence is not new, and yet there's nothing that's really happened, which is, I guess, quite sad. But there are so many factors to consider in things like PDPT, which has, laws that need to be changed, as well as PBS arrangements possibly needing to be made. So another thing that sort of was highlighted to me was the importance of advocacy and promoting change. Okay. These are some of my references. Any questions?
Thank you. That was an excellent presentation. You just touched on the point that I think it was 50% or so of medical practitioners said that they do this. Which country was that study conducted in? And if it was not Australia, do you see that as a useful extra bit of research?
I will double check. So that was, reference 12, which was, I'm not entirely sure.
It's unclear.
I think it might have been the US, which is where most of the evidence comes from, really.
Thank you.
Any other questions?
Oh, and just an additional point that if a clinician has a high index of suspicion for chlamydia, they may not necessarily wait for the test results to come back. So the test results could take a few days to a week, whereas you've presented with this option of giving them a medication and then just being done with it. That's sort of, sometimes done as well.
Greg Stewart, Sarah. So there has to be a law against this. You couldn't possibly be able to do it. So how are you going to deal with that?
Well, that's why they're hoping to change the law, and that's why they were requesting to the Department of Health whether they could review it. So the Northern Territory, which as I mentioned is the only state to so far change anything, they were lucky to be in the position of reviewing their legislation anyway, and that's how they managed to get it in.
Mike Acton, and just in response to that, our department is extremely, I think, engaged with the work that Sarah has done and is keen to do as much as can be done to get this implemented. It's clearly a difficult issue, but I think without Sarah's work we wouldn't be in the position to pursue it, as we will be. Thank you.
Sarah, this is a tangential question. This is not related to your study, but it's a public health question anyway. As I understand, chlamydia is a notifiable disease in Australia. It is not in New Zealand. What would be the use of notifications of chlamydia?
I think it helps inform the patterns of disease in terms of how common something is, whether they're increasing trends or decreasing, and which target population is being affected, and it helps you to target your management and any interventions.
Some years ago, I asked this question from the senior public health physician in New South Wales, and he said there's little use except for the fact that, okay, trends they can see, and the outcomes of any interventions. But he said they can find some clusters which they feel are worth investigating because they could also be linked to drug use and other things. May be possible.
Yeah, that's a good point.
I note you excluded men who have sex with men from the recommendations. I would have thought that the risks to women were greater than the risks to men. And I'd be rather inclined to exclude giving this treatment to men, giving the extra tablets to the men, expecting that they will look after the women that they have sex with. Because especially in this age group where, although I don't know much about it these days, my memory was, that was the 70s, that there was a lot of changing of partners, and when I was a university doctor back then, having a sexually transmitted infection was kind of a sign that it was over, and it might be so very much over that you don't even hand the tablets on, you might keep them for yourself for the next time it happens.
Okay. Well, when we go back to this slide about the rates of co-infection, so one study showed that 3.8% of females with chlamydia actually had deeper infection, so they wouldn't have been treated with that single dose of azithromycin. And another point is, even though it's safe in pregnancy, it would never be recommended first line for a pregnant woman. So as mentioned, PDPT is only intended as an additional strategy for those partners who you really don't think are going to be presenting. And the recommendation that would go along with any patient information you give them would be, even if you've taken these tablets, you are still at risk of other infections, and can you please, get tested and treated. Yeah.
Okay, thank you very much, Sarah.